Good evening, everybody, and welcome all of you to this live program on orthopedic principles. Today, our guest of honor is Dr. Yogesh Joshi from Wrexham, United Kingdom. Dr. Joshi is a consultant orthopedic surgeon at Wrexham Miller Hospital in the United Kingdom. He completed his orthopedic residency in 2004 and his FRC's orthopedics in 2011. He also holds an MSc in trauma and orthopedics from Wrightington, UK. Dr. Joshi's special interests are knee surgery. And if you've noticed, Dr. Joshi has delivered a couple of lectures on our channel and has already reached a huge audience. And today it's my great honor to bring back Dr. Yogesh Joshi for this wonderful live program. Over to you, Yogesh.
Thank you so much, Hitesh, for a kind introduction. I'm Yogesh Joshi. I'm one of the knee surgeons working in Wrexham Miller Hospital. This is a very good platform for all the trainees and the residents to learn new things about orthopedics and the procedures that we do day in and day out. It's a very important resource, and I would urge everyone to go through various videos in this orthopedic principle channel, where you could get a lot of information which would be helpful for your practice in future as well. Coming to this talk, so I work in Wrexham Miller Hospital, which is a DGH in North Wales. We do have a knee firm with 2 consultants, and we do lots of knee surgery, and anybody who is interested in observership is more than welcome to join us for a few weeks or months. So we are going to talk about the medial unicompartmental knee replacement, or a unicompartmental knee replacement. And we are going to talk about the technical goals, what we are going to achieve by doing the surgery, what is the approach to the surgery, the bony cuts and balancing bits, and addressing how to address the balancing issues in medial uni, and to how to avoid malalignment issues and complications, including dislocation of poly. In my practice, I use the Oxford medial unicompartmental knee replacement, which is a mobile bearing uni, and there are quite a lot of nuances in the surgery, and we'll go through each and every one in this presentation. So the design of Oxford Uni was in 1976 when John Goodfellow implanted. It was essentially started as a bicompartmental replacement and then designed to have a medial uni. Essentially, the design hasn't changed since then. So it's a spherical femur, a flat tibia, and a mobile bearing poly, which is completely unconstrained, fully congruent to the femoral and the tibial side. Now, because it's a mobile bearing knee replacement, balancing is essential. Now, in medial uni, especially in Oxford, the balancing is not by releasing the ligament structures, but we are balancing the ligaments by doing the bony cuts, and we'll see how we do that. So it's kind of a kinematic knee replacement. So in 1976, John Goodfellow devised this design and was mainly used for bicompartmental knee replacement surgery. And it's now more than 40 years since then. So there are 4 phases that we could compartmentalize this knee replacement and the evolution of the medial uni in Oxford. In the phase 1, there was only one size of the knee, medial knee, and only a saw was used. The indications was anteromedial osteoarthritis and no contraindications at the time. In the phase 2, the design and the instrumentation changed. So from saw, we went to a mill for accurate ligament balancing to balance the extension gap with the flexion gap, so that the dislocation rate of the mobile bearing component is reduced. And this was implanted more than 1,000 implants and had a good outcome at that time. In phase 3, we went to a minimally invasive procedure wherein the incision was made smaller, and that helped with rapid recovery of the patients. And in phase 4, we had the uncemented medial unicompartmental knee replacement with rough surfaces and hydroxyapatite coating to improve fixation as well as initial stability of the implant. And with the uncemented uni came the microplasty implants instrumentation, which is a very sophisticated instrumentation. And relying on this instrumentation is the key to get consistent and reliable results in medial uni. So the advantages of medial uni is faster recovery, short length of stay. So nowadays we are doing a day case uni replacement as well. In fewer major complications compared to a total knee replacement, less incidence of PE, MI, coronary vascular events. It reduces the mortality by more than half, and reduces the deep infection by more than half as well. And it has got excellent functional outcomes, especially in uncemented unis. The functional outcomes have been fantastic. Recent study, it was a randomized control trial with the TopCat results showed equivalent results compared to a total knee replacement. So indications is very, very specific. You need to have an appropriate patient for doing a medial compartmental uni replacement. Anteromedial osteoarthritis is a recognized entity, and it is very, very specific. So if you see here, this is the tibial side. It's the hemi-tibial plateau. This is the medial hemi-tibial plateau. And you can see the wear pattern is anteromedial, and that is the indication of medial uni. So this is a specific disease pattern. This happens only when the ligaments are intact and functional. So the wear starts from the anteromedial side, and as it progresses, it can then go beyond the mid portion into the posterior portion. Once it reaches the posterior portion, then it's not an indication for unicompartmental knee replacement surgery. If you see here, that's the anterior part and the posterior part. The thickness of the cartilage of the posterior part is intact, and that's very essential to understand so that we do the surgery in the right patient. So this anteromedial osteoarthritis can be diagnosed just by x-rays, so you don't need an MRI scan or anything else. So the criteria is bone-on-bone medial compartmental OA on the AP view. So if you see here, that's bone-on-bone, that's bone-on-bone, and that's bone-on-bone. All three can be an indication for a unicompartmental knee replacement. But if you see here, it's not bone-on-bone arthritis. So please be aware that you won't get, even if the MR scan shows cartilage loss, it won't have the same functional results as a bone-on-bone OA. On the lateral view, you have to look at the erosion pattern. The erosion has to be anteromedial. So if you see the anterior part of the medial tibial plateau is eroded, so that is an indication. This is an indication as well. If you see here, the erosion is anteromedial, but if you see posterior part, that is intact, that has got an intact cartilage in the posterior part. So that's a specific pattern that you need to understand. If you look at this X-ray, the erosion is on the posterior half of the tibial plateau. In these cases, the ACL is incompetent, and that's the reason the erosion is more posterior. Similarly here, the erosion is over the posterior part of the tibia, and that is an indication that the ACL is incompetent. You also have to have a valgus stress view. So if you look at the valgus stress view, you need to know what the functionality of the lateral compartment is. So lateral compartment needs to be functional. So in this X-ray, you've got a good joint space in the lateral compartment on the AP view, which is a valgus stress view. Similarly here, there is a good functional space between the two bones on the lateral compartment. Osteophyte on the lateral compartment is not a contraindication for medial uni. Similarly, if you look here on this X-ray, the joint space in the lateral compartment is reduced. So this is not an indication for medial uni. At the same time, on a valgus stress view, you see for the correction of the deformity. So in this case, the deformity is completely corrected. That means that the medial side structures, especially the MCL, is intact and functional. Similarly here, if the deformity is correctable, the MCL tension and the function is intact. Whereas here, this is a valgus stress view. The MCL is not functional, it is contracted. And in these cases, medial uni is contraindicated. Looking at the patellofemoral joint, cartilage loss is not a contraindication. Sorry, bone loss is contraindication for a medial uni. So if you look here, there is a medial facetal wear on the PFJ. Now this will get better because once you do a medial uni, it will offload the medial facet of the patella as well, and that will improve the function. Similarly here, and if you look at this side, the lateral facetal wear, there is no bone loss, there is only cartilage loss. Those function, the function of the medial uni is not compromised with these x-rays. But if you have an eroded surface, like a bone loss on the PFJ, that is a contraindication for a medial uni. These are the diagnostic criteria, and this can help in identifying patients for a unicompartmental knee replacement. So non-contraindications. So initially, in the last decade and before, we used to consider all these conditions as contraindications. So PFJ cartilage loss, anterior knee pain, obesity, chondrocalcinosis, extremes of age, and extremes of activities were considered contraindication for a medial UKR. Whereas now we know from various studies that these are not contraindications, and we can do medial UKR in these patients with equivalent results. So first thing was the indication. So if you do this surgery for anteromedial osteoarthritis, then you are going to get good results from this. The ligaments have to be functional. Now, in this technique, it is essential that the ligaments are never released, and the ligament balancing is done using bony cuts. So that is the crux of the technique for Oxford medial uni. Position-wise, you can position either as a total knee replacement with a knee in flexion with a bolster at the foot as well as side support. You need to have a 2 knee K on. You can do 2 knee K less surgeries because most of the time we do uncemented unis, so that's not an issue. I use a flexion of the knee with a knee bolster, with a foot bolster, although you can use a knee holder like so, which helps in the gap balancing much better. Although if you have to consider conversion of a uni to a total intraoperatively, this might be a bit difficult with this position. Incision, we go minimally invasive nowadays. So the incision starts with the superior pole of the patella at the level, and then go at parallel to the patellar tendon all the way down to the tibial tuberosity. Now, this incision is more than enough for a medial uni. And there are a few things you could do to improve your exposure. So you go through the mid-vastus approach, you cut the fibers of the vastus medialis, and that should help to sublux the patella laterally. Now, if the patella is not subluxing, then you can go further up so that the patella is relaxed and you can retract it laterally. The other factor that reduces the visibility is the fat pad. So you can take the fat pad away, and that should help you to see the ACL. It is very essential to make sure that the ACL is intact and functional during the medial UKR. So that can be visualized by subluxing the patella. We can also visualize the weight-bearing portion of the lateral femoral condyle at this juncture, so that we know that the lateral side of the knee is functional. Medially, you have to limit your release about a centimeter below the joint, so that we don't cut the medial collateral ligament. The soft tissues have to be preserved, and there is no need for release the ligament. The balancing is done by bony cuts. Following that, we take off all the osteophytes from the medial side, as well as around the PFJ area. There is usually a small osteophyte at the insertion of the ACL as well, which we take it out, as this can cause anterior impingement for the medial bearing. Once you have the exposure and you're cleared off the osteophyte, next step is to do the tibial cut. Now, there are three separate instruments. One is the spoon, one is the tibial jig itself, and then to link those two is what we call as a G clamp. It is shaped like a G, and it clamps the spoon and the tibial jig together, and that helps in precision as to what the depth of the cut is going to be. As you can see, this spoon goes all the way behind the femur, so it is referencing from the femur. As you know that in total knee replacements, you have an independent cut for the tibia and the femur, whereas in medial uni, especially the Oxford, you determine the tibial cut based on your femur. So the femur guides your tibial cut. And if you see in this diagram, that's where the spoon is. That's the G clamp, which links the spoon to the tibial jig. This is how it looks. This is the G clamp. It's shaped like a G, and that's the spoon. The spoons are of various sizes as well, and you could identify which size, medium, large, or small femur, and you can identify with the curvature of the spoon. So if you see if the spoon curvature fits the femur, that's the size of the medial UKR. And this also demonstrates how the spoon is connected to the tibial jig with the G clamp. And the G clamp are of two sizes, one is 3 and one is 4. And you can, what we tend to do is to do a cut with a G clamp size 4, so that we can downsize or upsize depending on the position. But usually this gives a very precise cut, and it should take, for G clamp 3 should take a 3 spacer, and for a G clamp 4 should take a 4 spacer. So once we do the tibial cut, there are two cuts. One is the vertical cut. Now this has to line at the junction of the downslope of the medial tibial eminence. It's exactly at the end of the ACL footprint. And if you see, it should direct towards the ASIS. And that's the flexion extension axis of the medial joint. So if you have to look at the wear pattern on the medial side, and that should also determine what is the flexion extension axis, and that's the direction of your vertical cut. If you see, the vertical cut should be parallel to the slope of the tibia. If you raise this hand, the saw might cut through the posterior cortex. And if you cut through the posterior cortex more so, it can fracture. So you have to be very cautious during this stage. For the horizontal cut, there is a slotted jig, and that helps with the horizontal cut. You protect the MCL throughout the procedure when you do the horizontal cut. And the biscuit that comes off shows the anteromedial wear pattern of the osteoarthritis, which is classical in most of these patients. You can see this is the stress finite analysis of medial UKR. You can see how the stresses rise after a medial UKR in the proximal tibia. And to diminish that, it's essential that we do the tibial cut in a precise way. And the microplasty instrumentation helps us to do that. And if you see here, the vertical cut is in the line of the medial eminence of the tibia, just at the end of the downslope at the footprint of the ACL. That's how it should be. And if you see here, that's the linkage between the G clamp, the tibial jig, and the spoon. And it gives exact, precise 7 mm resection of the tibia, which helps with a size 3 bearing. So this instrumentation achieves a very precise tibial cut. I'm going to share you animation for this. Have a look. So that's how the spoon goes. You detect the size of the femur through the spoon. So that's the correct size. Once you have the correct size of the femur, you can then connect the spoon to the tibial jig. That's the tibial jig, which goes in and into the varus valgus alignment to make sure that it's parallel to the tibial crest. This is a size 3G clamp, which goes on and locks there. So the tibial cut depends on the femur. Once you have this position, you can secure the tibial jig. And then the spoon comes out. Following this, we'll do the vertical cut, which is at the medial tibial eminence and at the footprint of the ACL. Make sure you protect the MCL, and then we'll do the horizontal cut. To complete the tibial resection. And this biscuit always shows the anteromedial wear of a pattern. So going back where we were, so the next step would be the femoral cut. So for the femoral cut, the instrumentations are very innovative, and they make sure you cut the femur in a precise orientation with a degree of flexion, as well as varus and valgus. So similar to the tibia, there are 3 components to this. So one is the intramedullary guide. Second is the femoral jig. And thirdly is the linkage bar. So first thing is to insert the IM rod into the femur, and then put the femoral jig between the femur and the tibia, and then link it with the linking rod. Now the link helps to determine the position of the femoral jig in 3 dimensions. So it will help you to achieve a 10-degree flexion of the femoral component. It will make sure that the varus and valgus alignment is correct of the femoral component, as well as you can medialize or lateralize the femoral component accordingly. And this gives a perfect position every single time. So it's quite reproducible and very precise. This is the femoral jig, and that's how you link the jig to the intermedullary rod with the help of a linkage bar. We'll have a look at the video again just to make sure we understand the concept of the linkage bar. So once you take the tibial biscuit, we size the tibia accordingly from the opposite tibial insert. And that's the correct size. So once you take the tibial jig off, that would be the start of the femoral preparation next. So that's the femoral guide. And this guide is the same measure as the G clamp. So if you're using a G clamp size 3 or a C clamp size 4, this is a corresponding guide. So the entry point is just a centimeter anterior to the incision of PCL. You open the hole up with a T handle and then insert the iron rod. The iron rod can be a short rod if there is a hip replacement above the knee. So then you put the femoral jig and then you link it with the link bar, and that should give you a correct orientation of the femoral jig. So you fix it with a drill bit, and then you drill with a 6 millimeter drill bit, and that would be the reference point for all the rest of the cuts of the femur. So once the position is determined, you do the posterior femoral cut by using a femoral guide, and that's how you cut the posterior femur. Now, remember, the posterior femur has got a good cartilage because the disease is anteromedial. So the thickness of the posterior cut should match the thickness of the implant. The next step will be to shape the distal femur into a sphere, and you do this with a mill. So you put a 0 spigot and then mill the distal femur to adjust the shape of the distal femur. You take the excess of bone off, and that will accommodate the trial implant on the femur. So when you put the trial implants on the femur and the tibia, and then we are ready to measure the flexion and extension gaps. So the flexion gap, this is a size 3 spacer. So that's a bit loose, so we put a size 4 spacer, and that appears to be well balanced. So the flexion gap is size 4. Now we'll check the gap in extension. That's a size 1. It wouldn't go, so the size in extension is 0. So the difference between the flexion and extension gap is 4 millimeters. And because there is a discrepancy, we need to take more bone off from the distal femur to accommodate the 4 spacer in extension. So you will put a 4 spigot and take 4 millimeter off from the distal femur to equalize the extension and the flexion gap. So you've taken 4 millimeter off, you're taking the excess bone off with a countersink and a bit of osteotome. And we are ready to again measure the flexion and extension gap. Hopefully this should be equal now. So you put the trial implants back. And we'll measure the flexion, which is 4. And it should go easily with 2 fingers. And the extension gap is size 4. So we have balanced the extension and flexion gap by not releasing the ligaments, but by taking more bone off. Going back to the presentation. The next step would be to prevent impingement. Now, because the medial Oxford Uni is mobile bearing, it's very, very important to take all the impinging structures off. Otherwise, the bearing can dislocate. So if the bearing hits the bone, it will angulate and it will tend to dislocate. If you look at the analogy of, if there are 2 bones compressing onto the poly, it will dislocate if it impinges because it's all dynamic. So if we have to remove the anterior bone with a mill, which is down here, so that's a mill to remove the anterior impingement of the femur. And similarly, for the posterior osteophytes of the femur, we use a chisel to take it out. And these are called impingement instruments, which are available with the microplasty instruments as well. We'll have a look how it works. It's very important to take these impinging structures off. So that's the anterior mill, and we'll take the anterior impinging structure off. And similarly, the chisel will take all the posterior osteophytes out as well. And that should have a balanced knee along with with no impinging structures in the knee. So once we have that, the next step would be keel preparation. We have got what we call as a toothbrush kind of a saw, which helps to prepare the tibial keel. And it's quite important to use this saw because it ensures that there is no fracture or impingement on the keel itself. And it is quite safe to do that because it has got a blunt end down here so that it doesn't go through the posterior cortex. And once you have done the initial keel preparation with the toothbrush saw, you can then use a gouge to clear off all the remaining bone. Here you can see how the tibial plate is being fixed using a temporary pin, and then use the toothbrush saw to prepare the tibial keel. And this is the gouge. You can take out the remaining bone from the tibia using this gouge. Looking for the tibial implantation, we use the uncemented unis because it has got a very good survival rate as well as good functional outcomes. So it has got 2 slots on either side. That is the inferior surface of the tibial component, and you can hold it with the component holder, and then you have to implant it with a toffee hammer. You should not be using a big hammer because there will be chances of tibia being fractured. So you have to be very gentle when you're implanting the tibia. And it has to land like an aeroplane. So you go down and go to the posterior most aspect, and then you come down in a vertical way. So that is going posteriorly, and then you can hammer it sequentially to the top as if you're landing the aeroplane. So once the tibia is implanted, similarly, you can implant the femur. The phase 4, the uncemented femur, is now twin pegged. So there are 2 pegs. So it improves the stability of the implant as well as it prevents any rotation of the implant. And then you can put the poly in, which is anatomical poly. It goes only one way. It has got a flat surface along the lateral side, which articulates with the vertical limb of the tibial plate. And it has got a rounded anteromedial side, which is quite anatomical and prevents impingement to the MCL and the soft tissues. Thank you very much.
Thank you, Yogesh, for that excellent lecture. Couple of questions from our side, Yogesh.
Yeah.
Now, Yogesh, you mentioned that the lateral X-ray is very critical to look at erosions, right? So when the erosion is going posteriorly, then you suspect that it is not an anteromedial OA, but it is also encompassing a posterior element as well. Yeah. But how easy it is to interpret the erosion? For example, you look at thinning of the cortices, right? So do you think you are likely to miss a posterior erosion, and do you think an MR should be made compulsory for a uni?
Not really. So it's to do with the contact point of the femur to the tibia. So if you look, where were we? So if you look at the X-rays, the contact point of the tibia is critical. So I'm just trying to find a slide where.
Yeah, it's in the initial part.
Yeah, I think.
Juggling is.
think it's the one after that. So if you look down here,
Yeah, exactly.
So it's the contact point of the femur that touching the tibia. So the contact point is center. And you can see you have to find where the medial, as we all know, the medial tibia is concave. So you just follow the concavity, and then you will see, if you follow that, there is a bump down here. So the posterior part is quite, preserved. Similarly here, if you see, the whole dish is going all the way posterior. So that is definitely a posterior erosion. It is sometimes difficult to make out, and that's the reason you have to verify it intraoperatively. You have to look at the ACL. So this erosion, anterior erosion, is only possible if the ACL is intact. So if the ACL is not intact intraoperatively, you convert the uni into a total knee replacement.
So you do not routinely get an MRI to look at posterior erosion, is it?
No.
It's not required.
Not required. So the decision is based on X-ray. So if you have a good quality X-ray, a good quality AP, lateral, a valgus stress view, and a skyline view, you can make a decision to do a uni even without seeing a patient. It's that accurate. So that's the diagnostic criteria, and it has got a decision-making a tool which is available through Oxford, and it's quite a reliable marker. But obviously you have to make sure that the ACL is intact during the surgery. And if the ACL is dysfunctional or not intact, then you have to convert it into a total knee replacement.
And just in continuity with that, when you say you look at ACL deficiency intraop, is it visual, or you do the Lachman and confirm it? How is it?
No, it's visual, so you can
Visual.
really see the whole full footprint. So once you take the fat pad out, you will see the whole ACL footprint. And now some striations might be acceptable in the ACL, but if it's torn, then it's a contraindication for uni compartment, and you shouldn't be proceeding with a uni if the ACL is incompetent.
Okay, and always you get a Rosenberg view, right? You get a PA in flexion, is it, or do you just take a conventional AP lateral?
The valgus stress is in 20 degrees of flexion, whereas the AP view is a standing weight-bearing AP view, because you have to know it's a bone-on-bone arthritis. So if it's not a bone-on-bone arthritis, you shouldn't be doing a uni.
No, there are some recommendations where you say that you take a PA view in some degrees of flexion, classically called as the Rosenberg view, isn't it? So
yeah, that's for the lateral. So
okay,
that's for the lateral OA. So if you have got a patient who you know clinically that the lateral side is tender and you're suspecting a lateral knee OA, then obviously a AP view won't show that. So the Rosenberg view is done so that the lateral OA is visualized, because as we all know, the lateral osteoarthritis, lateral compartment osteoarthritis, is a disease of flexion and not of extension. So the medial side is always an anteromedial wear, starts as an anteromedial wear, whereas the lateral side, it starts as a posterolateral wear. So that's the reason a Rosenberg view will demonstrate a lateral OA for you.
Thank you, Yogesh, for that. And what is the age group? For example, the classic uni was when Scott and Cousin described, I mean, many years ago, was in a patient who was like above 60 years. Do you think that definition has changed, those indications you do in slightly younger patients? And do you think there's an advantage of high arterial osteotomy in those younger patients?
Yes, it's completely up to the patient's personality. So patients is active and wants to go hiking and doing running and jogging and doing stuff, then obviously a high tibial osteotomy is better for that patient, because he will maintain the amount of function. The other indication for high tibial osteotomy in medial compartment OA is when it's not bone on bone. So if you get a medial OA which is not bone on bone and the function is person is high demand, then obviously high tibial osteotomy is the right indication for that patient. But if the patient has got bone on bone and has got the indications have completely expanded nowadays. So when initially it was thought that the extremes of activities and extremes of ages were a contraindication for a uni, it's not anymore. So you have to go with the patient personality. You have to give both the options to the patient, tell them about the pros and cons of each operation, and obviously the patient will decide which one is best for him. But for my point of view, if it's a bone on bone and the patient has got limited activity, then obviously a uni will suffice, and they have got an excellent functional outcome. And you have to be honest with the patient, saying that if you have to have a good functional outcome, a uni is probably better. The other thing about high tibial osteotomy is, if you have to tell the patient that the pain, that relief that they are going to get is to a degree, because the arthritic process is not taken away. So there will be some amount of discomfort even after doing a high tibial osteotomy. The benefits of a high tibial osteotomy obviously is to retain the high level function that they want to do. So it all depends on the patient's personality, your assessment of the patient, and what the patient expectations are, as well as patient preference to what they want as well. Most of the patients are now so literate, they've done the background work already, and they know exactly what they want or what they need.
And what about obesity or high BMI? Do you think high BMI, if I remember again Scott Carson's paper,
Yeah.
the very high BMI was actually a
Now,
contraindication. So has that changed?
yeah, so there are studies now showing that even in obese patient, high tibial osteotomy is not a contraindication. Although I will be cautious. They need to do all the non-operative measures first. So weight reduction is one of the non-operative modifiable risk factor. So if they have done their bit and done the weight reduction program and lifestyle modification program, and they have lost certain amount of weight, and they are quite positive, have got positive outcome, then obviously arthroplasty will suffice for them.
Thank you. Okay, just
But
one
from
last
the
question
point of the
before we wind up.
functional results, from the point of functional results, obesity is not a contraindication. The results from medial UKR in Oxford are similar for obese and non-obese patients.
Thank you, Yogesh. Just one last question before we wind up the session. Now, one of the problems or a disadvantage for a mobile bearing uni is a spin-off, right? A poly spin-off. So have you encountered that in your practice, and how do you deal with it? I mean, the ligament balance is always a key, isn't it? When you talk about in a conventional totally, what about in a uni?
In a uni, it's very critical, and that's the reason this, sorry, the microplasty instrumentations are critical. They are so precise that you're balancing the ligaments by about 1 millimeter plus or minus. So it's very, very precise instrumentation with very precise outcomes. So if you are using a 4G clamp, you will be inserting a 4 poly. Very rarely you go up or down the poly. It is so specific. So because of the precision has improved, the rate of dislocations have reduced. And the spin-off was mainly because of impingement rather than balancing itself. So, and they have come up with this anti-impingement tools where you take the whole anterior part off by the mill and the posterior part by the chisel. That's the whole idea of getting away with the impingement. Also, I would say that, if you have to get back the physiological laxity of the MCL, so you do not want to overstuff the medial compartment. If you look at the analogy where you are pressing a wet soap in your hand, it slips out. So, if you overstuff the medial side, it will slip out, especially if there is impingement. So if you take away impingement, if you use the microplasty instrumentation as they have described, there is very little risk of poly dislocation. Most of the results, the risk of dislocation is 0.5%. So it's already low. And with this kind of instrumentation, it has gone really rare.
Thank you, Yogesh. I think that's all the questions that we have for this session. Thank you for yet another fantastic lecture, and I'm sure this is going to benefit a lot of people all over the world. Thank you so much, Yogesh, for joining in.
Thank you. Thanks so much.
Bye-bye.